Estou começando o programa Infertilidade em Foco, diretamente da TV Faz, Rio de Janeiro. O nosso programa trata de assuntos, temas sobre infertilidade humana. E a cada semana, um convidado representa um país, sendo o melhor especialista no mundo. Hoje, o nosso convidado estará representando o país Índia, um país maravilhoso, onde eu tenho muitos amigos e estou completamente apaixonada pelo lugar. O nosso convidado de hoje, representando o país Índia, Dr. Niraj Jadhav. Dr. Niraj é presidente do Comitê de Medicina Sexual da Índia, Foco. Também foi presidente e vice-presidente do Conselho de Medicina de Obstetrícia na Índia. Ele, que é presidente, coordenador de várias conferências nacionais e estaduais. Inclusive, em setembro, terá uma conferência maravilhosa na Índia, onde eu fui convidada para participar. Eu agradeço, Dr. Niraj, pelo convite. O nosso tema da palestra de hoje é um tema muito importante. Iremos falar sobre sexualidade. Sexualidade é um tema que eu gosto muito. Eu trabalho com essa área de educação sexual em escolas e colégios. E hoje o Dr. Niraj irá falar sobre sexualidade, saúde sexual, disfunção sexual feminina. Um tema que é de essencial importância na área de fertilização humana. Vamos assistir?
Hello. Namaskar. Myself Dr. Niraj Jadhav. I am from India and past chairperson of Sexual Medicine Committee Foco. I would like to thank Bell for inviting me to share my views on the female sexual dysfunction. So let's start. Let's first discuss what is sexual health. According to current working definition, sexual health is a state of physical, emotional, mental and social well-being in relation to sexuality. It's not merely the absence of disease, dysfunction or infirmity. Sexual health requires a positive and respectful approach to sexuality and sexual relationship, as well as the possibility of having a pleasurable and safe sexual experience free of correction, discrimination and violence. For sexual health to be attained and maintained, the sexual right of all the person must be respected, protected and fulfilled. So what is female sexual dysfunction? Female sexual dysfunction implies persistent or recurrent problems encountered in one or more stages of the sexual response. It is not dysfunction unless the woman is distressed about it or it negatively affects the relationship. So there are four phases of sexual response. One is desire, arousal, intromission and the last is the orgasm or resolution. So accordingly, female sexual dysfunction can be divided into desire phase problem, arousal disorder, orgasmic disorder and sexual pain disorder. If you look at the classification of female sexual dysfunction, desire disorder can be hyperactive sexual desire disorder, sexual aversion disorder, then sexual arousal disorder, then the orgasmic disorder, and the sexual pain disorder can be dyspareunia or vaginismus. In DSM-5, that is a latest classification that came in 2013, there are certain changes. Female hyperactive sexual desire disorder and the female arousal disorder have been combined in a single entity, that is a female sexual interest or arousal disorder. Female orgasmic disorder is the same. while dyspareunia and vaginismus again clubbed in a single entity, that is a genitopelvic pain penetration disorder. So let's discuss the first dysfunction, that is the female sexual interest or arousal disorder. So how we label patient is having interest or arousal disorder? There are 6 criteria, and out of these 6, 3 should be present before you label your patient is having the desire or arousal problem. Absent or decrease in the sexual interest, absent or decrease in the erotic thoughts, and absent or decrease in the initiation of the sexual activity or responsiveness to partner's attempt to initiate it, absent or decrease in the excitement and pleasure during the sexual activity, absent or decrease in the arousal in response to the sexual cues, and absent or decrease in the sensation during the sexual activity, whether genital or non-genital. And to further describe this dysfunction, all this also should be present. That this should be present at least 75 to 100% of the time of the sexual encounter, and minimum duration should be 6 months, and it should cause the significant distress to the patient. Then only you can label as a dysfunction. So if you look at the prevalence, it is roughly around 26 to 43% prevalence rate found in the various studies. If you classify, it can be either lifelong or acquired or generalized or situational. There are so many barriers for the diagnosis, because women often do not spontaneously mention this issue to their healthcare providers. So there is a barrier for a diagnosis. Then look at how we can evaluate this patient. Recognize the underlying condition that contribute to the reduced desire and arousal. Then we have to inquire about the major relationship or physical issues. Then detailed information from the patient about their experience of low desire, about the onset of the problem, about the duration, behavioral adaptations and avoidance, and the level of distress we have to inquire from the patient. Close evaluation of patient's medical history, including the reproductive history. Then we have to inquire about the comorbid conditions like endocrine issue, neurological issue, cardiovascular issue, and the psychiatric disorder, and the use of prescription and the OTC medications we have to inquire. Then complete gynecological history, any sexually transmitted diseases, history of sexual abuse, urinary or bowel complaint, and any prior surgery we have to inquire from the patient. Psychiatric disorder, particularly depression and anxiety, we have to check whether the patient is suffering from not. And targeted physical examination is required after history. Specific test based on the history and the physical examination, and the pelvic examination is highly recommended to find out the occult organic causes, physical factors, or any unknown comorbidities. Coming to the management part, goal of the treatment is to improve the quality of life, creating sex positive, open-minded, pleasure-based approach, should be client-centered and goal-oriented, and it should be result-driven. Initial counseling should be office-based. There are various methods available like Precit model, Allow model, MEBS model. Precit model is permission, limited information, specific suggestion, and then after all this intensive therapy should be there. So that is a Precit model. Then psychological intervention is very much important, like sensus focus. Sensus focus is a sex therapy technique that works by refocusing the participants on their own sensory perceptions and sensuality, and instead of goal-oriented behavior, it focuses on the genitalia and penetrative sex. Then cognitive behavioral therapy, it serves the changes in the sexual behavior by focusing on pleasure and not on the sexual form and planned sexual activity, and it focuses on the sex exploration instead of avoidance of the sexual activity. Then there is a mindful based cognitive behavioral therapy And the goal is to encourage participants to connect and engage with their sexuality by learning and practicing a variety of mindfulness exercise that attempt to improve awareness of here and now and acceptance and the self-compassion. Therapy also includes the educational component regarding female sexuality and the sexual function. Then there are, if you look at what are the medication available to manage such type of patient, there are flibanserin, testosterone, buspirone, bremelanotide, DHEA, and sildenafil. Out of all these, flibanserin and the bremelanotide only are the FDA approved. Flibanserin dose is 100 mg at bedtime, but it is contraindicated when patient is using alcohol or there is a hepatic impairment. Then coming to the bremelanotide, it was approved by FDA in 2019. It available as a injection, tablet, as well as the nasal spray. Usually 1.75 mg injection, subcutaneous injection, particularly in the premenopausal women, once in a 24 hours, not more than 8 doses per month, and it should be given 45 minutes before the activity. And if it doesn't work, we have to stop the injection after the 8 weeks of the treatment. Then if it is a menopausal age group, then we can put pressure on systemic HRT, we can put on the tibolone or local estrogen therapy. All these can improve their desire particularly in the menopausal group. Then this was all about the interest and arousal disorder. Then coming to the second disorder, that is the female orgasmic disorder. So how you define the female orgasmic disorder? It is characterized by persistent or recurrent distressing compromise of orgasmic frequency, intensity, timing, and or pleasure associated with the sexual activity for more than 6 months. Frequency, orgasm occur with the decreased frequency or it is absent. Intensity, orgasm occur with the less intensity. Timing, orgasm occur either too late or too soon. And the pleasure, orgasm occur with the absent or decreased pleasure. So prevalence is usually, if you look at the various studies, it is around 10 to 42% in the general population. Again, it can be either lifelong or acquired or generalized or situational. Then coming to the evaluation, detailed sexual history from both the partner, physical examination of both the partner, then some of the laboratory investigation depending upon the history and the examination, and psychiatric evaluation is the most important in such type of patient. Then coming to the management part, we have how we can manage. There are sex counseling, supportive psychotherapy, sex therapy, marital therapy, behavioral modification therapy, clitoral devices are available. Then there are vibrators and dildos is available, and some of the medication like PDE5 inhibitor or prostaglandin cream and some of the phytochemicals are available to help such type of patient. So in such type of patient, education is very much important about the female sexual anatomy and how different parts of anatomy respond to the stimulation. Then there is a directed masturbation technique. This is a program of instruction and at-home exercise that helps the patient to become familiar with their own body and explore the self-directed sexual stimulation. After learning to achieve orgasm, the knowledge about what is learned is practiced with the partner. And there is a sensor focus therapy to help this patient. Sometimes change in the sexual position also help such patient. Then there are sexual enhancement devices that enhance the sexual stimulation, may assist the patient in having a better orgasm. This include the vibrator and the air pulsating devices that stimulate the clitoris. Then there is a cognitive behavioral therapy. Coming to the medical or pharmacotherapy, if it is in the menopausal age group, we can put patient on the estrogen therapy or testosterone therapy, which in some cases solve the problem. Then coming to the last part, that is the painful sex. Painful sex, it is we all know it is a three component: dyspareunia, vulvodynia, and the vaginismus. Dyspareunia is genital pain associated with the sexual intercourse. Vulvodynia is the vulval discomfort, most often described as a burning pain during the occurring in the absence of the relevant visible finding or a specific clinically identifiable neurological disorder. And vaginismus is a non-organic spasm of the pelvic floor muscle that surrounds the vagina, that causing the occlusion of the vaginal opening, that makes the penile entry either painful or impossible. But recently, all these have been combined in a single entity, that is the genitopelvic pain penetration disorder. Dyspareunia can be either superficial or deep, it can be either primary or secondary, it can be permanent or intermittent, it can be situational or generalized, and it can also be with or without the vulvodynia. Superficial dyspareunia may be due to because of vulvovaginal infection, inadequate lubrication, congenital anomalies, obstetric causes like episiotomy scar, vulval varicosities, vulvovaginal atrophy, urological disorder, muscular disorder, and deep dyspareunia can be because of the genital infection, cervicitis or PID, pelvic adhesion, endometriosis, adenomyosis, retroverted uterus, genital prolapse, all can lead to the deep dyspareunia. So, coming to the management part, how we manage this dyspareunia, we have to treat the what is the causing the pain. Like if it is a vulvovaginitis, we give antifungal treatment. If it is vulvovaginal atrophy, we put patient on the estrogen therapy. If there is an infection, manage that infection. If it is endometriosis, it can be either managed by pharmacological or surgical management. And if it is retroverted uterus, fibroid or adhesion, then you have to go for the surgery. Coming to the vaginismus part, how we manage patient, we can first of all we have to assure the patient that the management is possible, because there is so much fear in the patient mind that they are it's very difficult to counsel such type of patients. So detailed counseling is very much important. Sex education is very much important. We can put patient on the lubricant, anesthetic cream, pelvic floor exercise. Then there is a systemic vaginal desensitization, pharmacotherapy in form of anxiolytic, then sex therapy in form of the sensate focus, and recently there is a Botox or botulinum toxin. So coming to the desensitizing with the using with the dilator, there are they are available in the various size from the 19 to 35 millimeter. And it is also available in the various material like it available plastic, silicone or glasses. And progressive larger dilator helps to stretch the vagina and allow the woman to become comfortable with the vaginal penetration. Then if a patient is very much afraid, then we can put patient on the anxiolytic or anti-depression. Then recently there is a Botox. It is given in the lateral vaginal wall, but we have to avoid the urethral opening and the rectal opening because it can lead to the incontinence. When you give the Botox injection, the effect is temporary. It starts within 7 to 10 days and usually lasts for the 3 to 9 months. But usually single sitting with the Botox injection is sufficient to manage most of the patient. But Botox injection is usually required in less than 10% of the cases. In 90% of the cases, with the counseling, with the sex therapy and the desensitization with the dilator will solve the problem in most of the patient. Then coming to the menopausal age group, that is GSM patient, what are the available treatment with us? We have a moisturizer and lubricants, estrogen, androgens, DHEA, tibolone, and the selective estrogen receptor modulation. What is the difference between moisturizer and lubricant? Moisturizer is it gives a longer long-lasting effect, while lubricant is for the temporary use. We can put patient on the estrogen, local estrogen cream. DHEA gel is also available in some countries, which is also beneficial to such type of patient. So I think that is all what I want to say about the female sexual dysfunction. And there are so many advances about the male sexual dysfunction, but there is a very limited invention for the management of the female sexual dysfunction, because female sexuality is a very complex phenomena. So I hope in future there are more and more invention to understand this problem, and we can offer more option to the patients suffering from the female sexual dysfunction. So thank you.
E vamos dar início à nossa entrevista de hoje com o nosso convidado, Dr. Niraj. Ele que é presidente do Conselho de Medicina Sexual da Índia, Foco. Dr. Niraj, culturalmente, como as mulheres indianas lidam com a sexualidade?
Yes, sex is, even in the 21st century, is a taboo for women, and it does affect the sexuality, and it compromises the sexual health of women. Basically, woman is considered as a passive partner when it comes to sex, and we, in generally all over the world, we are the male dominant society. So there is a gap between the how male and female sexual health are perceived in general. In many societies, discussions around women's sexual health remain taboo even in 21st century. This taboo can indeed impact the sexuality and can compromise sexual health. So let's understand how it affects them. Because there is a lack of information, there is a stigma, there is a discrimination, and there are certain cultural norms. The persistence of the sexual taboo for women can be attributed to a complex interplay of the cultural, historical, and the societal factors. So let's understand some of the factors. First is the historical context. Throughout history, women's sexuality has been tightly controlled due to patriarchal norms. Women were often seen as a property and their sexual autonomy was restricted. This historical attitude continues to influence the perception even today. And then there is gender role and expectation. Traditional gender roles cast women as a caretaker, nurturing mothers, and the modest individual. Any deviation from these roles, including open discussion about sex, can be met with the judgment or with the same. Then there are double standards. Society often holds women to different standards than men. Men may be praised for sexual conquest, while women are often labeled negatively for the same behavior. This double standard perpetuates taboo around the female sexuality. Then there is a fear of empowerment. Open discussion about the sex can empower women by providing knowledge and by providing agency. Some fear that this empowerment might disrupt the existing power of the dynamics, or it can challenge the traditional norms. Then there is a religious and cultural belief also play an important role. Many religious and cultural teachings emphasize modesty, chastity, and the sexual purity. This belief can contribute to the taboo surrounding the woman's sexuality. Then there is a role of media and entertainment too. Media often portrays women's sexuality in a narrow, sensational way. This can reinforce the stereotype and discourage open conversations. Then there are health and safety concerns also. Fear of judgment or repercussions may prevent women from seeking sexual health information, or they prevent discussing their needs openly. So there are all these factors, and if you look at the research in the field of the sexual health, there are so much research for the male sexuality and the options are available for management of the male sexual dysfunction. But when you look at the other side of the spectrum, hardly few options are available regarding the female sexual dysfunction. So there is a clearly bias toward the male and there is a negligence about the women when it comes to the health as well as the sexual health also of the our women. Uh, Sexual dysfunction, yes, really can cause the emotional disorder and it can interfere with the sexual activity and prevent the fertility. Each unsuccessful month of trying for pregnancy leaves women with a greater sense of concern, anxiety, guilt, blame, or anger at not becoming pregnant. The ability of reproduction is closely connected with the self image, self respect, and the sexuality. Sexual intercourse may lose its spontaneity and the erotic value because the main aim becomes the conception. This may affect the ability for intimate sexuality and can provoke the many sexual dysfunction. The treatment of infertility dictates the frequency, the timing of sexual intercourse, the usual intimate event become regulated, controlled, and couple often sense that the medical team is symbolically present also in their bedroom during their most personal act. Problem often occur due to the emotional impact of the diagnosis and the forced and the dictated sexual relationship as a part of the treatment and the management of the infertility treatment.
Doutor, qual o principal empecilho para se chegar a um diagnóstico de disfunção sexual feminino e como se faz para fechar esse diagnóstico?
Sexual dysfunction can appear in both the partners and might provoke problem in every stage of the sexual response. Sexual dysfunction can be a reason of infertility or it can be triggered by infertility. So it has both vice versa true about the sexuality and the infertility. Uh, about the if you look at the obstacles regarding the diagnosis of sexual dysfunction, there are many barriers uh, like perception. Some people don't view sexual problem as serious or they may be comfortable with the status quo. They don't want to go into the difficult part of the going to the consultant and taking the treatment for their sexual problem. So they are happy with the whatever lacunae in their sexual life. And sometimes it's not considered as a medical matter. Some individuals don't recognize sexual issue as a medical concern, so they avoid the sexual health. Then there is a stigma and shame. Shame associated with the sexual problem can discourage seeking the medical help. If we look at the female sexual dysfunction is a complex and poorly understood condition that affects approximately 40% of the women. However, discussing it with the healthcare provider can be challenging due to so many factors. One is the lack of awareness. Many healthcare providers are uncomfortable asking about the sexual dysfunction due to the inadequate knowledge and training in the diagnosis and management of the sexual health issues. Then there is a time constraint. Clinical time constraint often hindered through the discussion about the sexual health because there are so many busy OPDs there. They have to go to the OT, and we all know that the sexual health to discuss about it, it requires long counseling hours, and sometimes it become difficult. Then there is a privacy concern. Patient may feel uncomfortable discussing the intimate issue in a clinical setting. They are not that much comfortable sometimes. Then there is a linguistic challenges. Language can be sometimes be barrier because what happens get patient describe their try to explain to the medical personnel about the problem in their own language, and sometimes the healthcare provider don't understand what they are trying to say. So there is a language barrier, particularly when it comes to the sexual health issue, because what is normally seen as the because of the so many factors, people are using some different language or some decoded word to express their problem. So sometimes it becomes difficult to identify the problem.
Dr. Niraj, você, como presidente do comitê da Fox, como os especialistas fazem para conscientizar a população sobre a saúde sexual na Índia?
Then there is a socio-cultural factors. Cultural norms and the stigma may discourage about the open conversation about the sexual problem. Regarding how to raise the awareness in the population about the sexual health. Let me tell you frankly, it's very difficult to answer that question because we also are trying to figure out what is the best way to raise awareness. Certainly, it's a much needed awareness required in the general population. Raising awareness about the sexual health is a crucial for the promoting well-being and informed decision making, because sexual health is a very important component of the overall health, and if you ignore the sexual health, you can't improve the general health. And there is a also lack of the quality of life because of the sexual health issues. So first is the how we can promote about the awareness is the educational and awareness campaign. We can collaborate with NGO to create the campaign that provide the comprehensive information about the sexual health. This campaign can be shared via social media, through website and other platforms. Then integration into the holistic healthcare. Integrate sexual health discussion into oral healthcare is very important. Address sexual health as a vital aspect of well-being. Me being as a gynecologist, patient, we come across patient from the adolescent, when patient is pregnant, when patient is suffering from infertility, when they are having any gynecological problem, or even in the menopausal or perimenopausal age group, patient come to us for various problems. So this is the best time to catch up them. We can try to initiate the conversation about the sexual health, and this will definitely help to raise the awareness, particularly for us gynecologists, about the sexual health in the woman. And also as a consultant, whenever you see any patient, male, female, adolescent, any age group, you can try to open up the discussion about the sexual health. That will certainly help, and it will go in a long way to raise the awareness. Then digital tool and the social media. We all know how powerful in today's era is the digital tool and the social media. Leveraging the digital platform to disseminate the accurate sexual information, to engage with the audience through the social media, through website and through apps is very important. Particularly youth is very much techno savvy, and they prefer to get the knowledge about all the health aspect through the social media. So this is a very good medium to raise the awareness. Then training and the continuing education is also important, providing the ongoing training for the healthcare professional to equip them with the up-to-date knowledge about the sexual health is a much needed, because if they are not comfortable and they are lacking the knowledge, how medical professional will raise the awareness. So that's also a very important point. Then community partnership. Collaborate with the community organizers, with the school, with the local leader, to organize the workshop, to a different event about the sexual health and the awareness drive we can do with all of them. So that will certainly help in the raising awareness. About the scenario of the sexuality education in the school. Yes, there are efforts in India to provide the sexual education in school in India. However, implementation is bit variable in different parts of the India. There are some ways where this activity are going on, like adolescent education program is there by the government. It aims to provide the information on the health and right for the adolescent, and it includes the aspect of the sexuality education. Then there is a school health program, a government-led initiative that address the health-related topics for the student. However, the problem is that the extent of the sexual education within this program, it's very limited, and it differ from different schools. And there is a private school. Some of the private school associated with the central board of the India, they provide the sex education in their syllabus. However, most school, which both private as well as public, associated with the state organization, do not have a formal sexuality education in their curriculum. Then standardization of the curriculum is very important, because while health and physical education are part of the curriculum, the emphasis tend to be on physical activity and the health checkups rather than the providing them the comprehensive sexuality education. So, in summary, there are efforts to introduce the sexual education in the school, but there is a still room for the improvement in the term of the consistency, and in the terms of the depth of the coverage is very much required.
Dr. Niraj, eu acredito que o parceiro seja de primordial importância para auxiliar a mulher nesse tratamento de saúde sexual. Como os homens indianos reagem e ajudam as suas esposas e seu parceiro sexual nesse tratamento?
Then about the what is the difference between sex and sexuality, and what is the role of men. So there is a vast difference. If you see, sex is a like sea, while sexuality is a like an ocean. So sex is a part of sexuality. Sex is particularly physical act of intercourse, and it is an intimate expression of love, while sexuality is a sum total of one's thoughts, feelings, behavior toward the opposite sex. Sexuality is a total expression of who we are as a human being. It is more than the act of sex. It includes the physical, emotional, and spiritual part of our being, and it involves our personalities and our values, attitude, gender, thoughts, feelings, and our sexual behavior. And sexuality is not static, it is a constantly evolving process, and as we grow and we develop, it also sometimes change over the years. Sexuality can change over the time.
Qual a diferença entre sexo e sexualidade?
Then sexual dysfunction is stressful for most men, because they feel it is a challenge to their manhood, because this is a stereotype that men are should be the very proactive when it comes to sex, and to accept that they have some issue about their sexual health is a really challenging situation for them. It's very difficult for most of the men to accept that they are having some issue, and usually they don't seek the medical help for the problem through qualified person. They try to search the net, they go to some non-medical person or quacks to get their problem solved. So it's a not that much easy also on men's part to about their sexual health issues. Sex therapy. Let's talk about the sex therapy. What is it? Sex therapy can help people identify and work through their sexual challenges, such as the low sex drive, painful sex, difficulty having orgasm. It can help to improve the sexual satisfaction. Sex therapy does not require both the partners. Some people may benefit from individual therapy also, while some may find couple sex therapy more useful. So it depends upon case to case and individual to individual. Sex therapy is a type of talk therapy designed to help the individuals and couple who are experiencing the issue about to achieve the sexual satisfaction. Physical, psychological, and emotional factor can all cause sexual challenges. Sex therapist's goal is to help the person or to couple to address their issue and to obtain a more fulfilling sex life.
Doutor Niraj, essa pergunta eu estou ansiosa para saber a resposta e muito curiosa. Como é feito a terapia cognitiva do sexo? Tem como fazer de forma online?
Sex therapy does not involve sexual contact between the client and the therapist. Generally, the client and the sex therapist discuss any experiences, emotions, and the concerns that may contribute to the client's sexual dissatisfactions and the challenges. They will also work on the coping mechanism to help them build a more satisfying sex life. Sex therapist might also give their client homework. This may vary depending upon the individual or couple and can include the assignment designed to increase the sexual education, to improve the communication between the partners. Sex therapist also may assign sexual experimentation, and some of the exercises like sunset focus, mindfulness exercises are there to help such couple or individual. A benefit of the sex therapy is that the sex therapy can help both the individual and the couple. It gains a realistic understanding of sex and the pleasure. It identifies and addresses the underlying cause of the sexual issue. It can grow and maintain a deeper sexual connection with the oneself and with the partner. So there are so many advantages of taking the sex therapy if one's sex life is not good.
Agora, vamos para a nossa última pergunta da nossa entrevista. Eu vou dizer 3 palavras e o doutor me diz o que vem em sua mente. Infertilidade, gravidez, Índia.
So, infertility, what comes into my mind is it is a most distressing condition for individual or for couple. Pregnancy, it is a dream of every woman to become mother, and it is a joy every couple want to achieve the pregnancy. And India, what I tell, India is a founder of the sexual health when it comes to sexual health, because Kama Sutra was invented here. We have so much rich heritage. We have a sculpture in the Khajuraho and so many other temples which gives details about the sexual health, how one should behave, how one can have a better sex life. So India is a very rich when it comes to the sexual health, how to tackle the raise sexual health. So our past was very much we have so much science, and they were the old scientists in our culture that promoted the sexual health. So thank you.
Good morning, everyone. Bom dia. I am Professor Zevos. I'm the director of the Andrology Institute of America in the USA. And I'm here this morning to announce to the people in Brazil that we are introducing a very revolutionary methodology for treatment of secretory azoospermia, meaning that for people that do not have any sperm in their ejaculate, they can be rejuvenated in a way via which we can perfuse their testes and introduce stem cells in collaboration or in conjunction with PRP and exosomes, and allowing those testes to get rejuvenated and begin to produce sperm in men that do not have any sperm in their ejaculates. Azoospermia, lack of sperm in the ejaculate. This is a revolutionary method, and that we are introducing it for the people in Brazil, and we're delighted that Dr. Belle Cirne is representing our technology and our know-how and expertise via her expertise in Brazil, this revolutionary modality for treatment of azoospermia. And we look forward to hearing from you as our patients in Brazil. And the best thing to do is obviously get in touch with Dr. Cirne and her group. And we look forward to possibly allowing the patient to establish a level of communication between us via consultation, and then following that up to receive the treatment for the treatment of azoospermia. We are very excited to be working with Dr. Cirne in Brazil, and we look forward to working with you and assisting you in regaining your ability to produce sperm and become a parent, to procreate. We thank you for listening to me, and have a wonderful day. I am Professor Zevos from the Andrology Institute of America, and I thank you.
Estou encerrando o programa Infertilidade em Foco. Quero agradecer ao Dr. Niraj, representando o seu país, a Índia. E esse agradecimento se estende a todos os membros do comitê da Fox, também a todos os membros da Sociedade de Obstetrícia da Índia. Quero agradecer também aos telespectadores do Brasil e do mundo. Dani Abate. Namastê. Até o próximo programa.
Thank you.